Hello, everybody, and thank you for joining us for another one of our wonderful Meet the Specialist sessions. May I ask those of you who have joined us today if you could please put your microphone onto mute so that any noise from your home or workplace doesn't disrupt the quality of the recording. There will be an opportunity to ask questions at the end of the session. Today we have the very lovely Dr. Amith Shetty, who has an amazing amount of credentials that he will tell you all about. He has been with our panel for a short time, and we are very, very honoured to have him with us. He works in the field of accident and emergency medicine. And so without further ado, I will hand over to you to introduce yourself and let us know a little bit about what you do and how what you do relates in the personal injury and IME space. Thank you so much.
Thanks, Michelle. Hi, everyone. I'm Amith Shetty. I'll start by acknowledging the traditional owners of the land on which I'm dialing from today, which for me, it's the Gadigal people and all the areas you're dialing in from as well. Look, I'll go through my little life journey and then I'll throw it to you guys to say what you think and what more you need to know. So I did my medicine. I'm originally from India. I did my medicine in Bombay, finished in 1997, came to Australia first in 98 just to do the AMCs, traveling up and down. And then once I finished my AMCs, I moved here in 2000. I started working here in 2001 as a resident in Liverpool, then multiple different hospitals, and settled in Westmead, where I did my specialist training, and I became a star specialist in 2012. I like to party a lot, so I did a lot of partying, didn't do my exams in time, but when I did it, when I found my wife, is when I decided maybe I need to start doing those exams and get my specialist qualification. So I got those in 2012. And then, but my passion during that time has always been infection research and medical management as well, on top of emergency physician practice. I've been a star specialist at Westmead since, and now I'm a senior star specialist. I've been deputy director for the department in the past. I've been a director of hospital in the home for Western Sydney as well. So whilst I have continued to keep my CPD going, I also had interest, like I said, in research and management. So I've done significant executive qualifications from Harvard Public Health for project management, healthcare leadership. From Harvard Business School, I'm just finishing my certificate management excellence, finished healthcare management from Harvard Business School as well, and leadership training at London Business School as well. And did a PhD in sepsis and infectious diseases, and that finished that about 3 or 4 years ago. So in parallel, I've been doing a lot of RCAs, clinical incident reviews for the state. So about 5 years ago, one of the deputy secretaries so we've got Secretary of Health and then the Deputy Secretary of Health in our divisions, who reached out to me and said, look, because I was the state chair for research as well, and state chair for the sepsis management pathways as well, so it's quality safety chair. So she reached out and she said, you seem to be doing multiple different things. So I always say that I do that because I've got undiagnosed ADD. I just keep myself busy doing all these things. So she asked me to come and join in the ministry. So I've been at the Ministry of Health. So I do very little clinical work now, but just to keep my CPD going. But I do statewide management of and review of incidents, but also during COVID, I was in charge of all the COVID-related analytics. So all the graphs you saw on TV was coming from our teams. I designed the RAT registration system, so the surveys, the SMSs, the entire electronic digital pathways for management of COVID. And I was the director for COVID care in the community. So I got the New South Wales Health Awards and the Premier's nomination for the work I did during COVID. And now I'm doing access to care pathways, converting all those digital pathways for the state. So I'll stop there. I do have some other roles as well. I'm the New South Wales rep for digital health. So any of those digital health kind of issues as well, I'm an expert in. And like I said, I'm the New South Wales rep to the Australian Digital Health Agency. I do a lot of work around costing and for the state as well. So I'm the rep for New South Wales for the independent hospital pricing authorities as well. So quite a deep insight of not just ED, but then how the entire system works. So apart from, so I'll leave it there, but happy to. But I've done, so most of those famous sepsis related deaths in the last 10 years would have gone through my reviews, because I usually do them for New South Wales. So that's why I usually avoid taking any New South Wales cases, because I work in the system management in that space. So it becomes a sort of conflict of interest for me to get involved in public hospital cases in New South Wales. So.
Fair enough. Fair enough. Now, you mentioned the sepsis thing, and I did see with great interest the work that you've done on that. As somebody who once got sepsis myself when I had tonsillitis. And the thing that I noticed about that, which was explained to me by my care team at the time, was the critical importance of people in the emergency space identifying the possibility of a sepsis, and then the pathways that needed to be followed to safely manage that person and stop a serious escalation. Can you tell me a little bit about how you would look at a matter and determine whether the pathways had been followed properly or not?
So I've got about 17 publications on sepsis, and I designed electronic alerts and those pathways for the sepsis pathways. So when you review a case, you can actually, from clinical assessment itself, presenting problem, the triage category, whether they've done a full set of observations. I find one of the biggest, most of the trends where I've seen these reviews myself in the cases I've reviewed, there is a lack of that point where you said the lack of insight of thinking that this could be sepsis. And then what that leads to is almost a bias towards, and especially in the young people, the elderly and the really sick ones get picked up because they get they come by ambulance, they've got all the observations done. It's usually the ones in the middle who are looking well, slightly off. They get labeled as the flu. They'll usually get a flu test done rather than blood test for infection. And then when they get sicker is when they come back. First thing I always do is check for past records. So a few of my cases where I've reviewed, especially coming from country towns, they've presented to the hospital a couple of times before with just vague symptoms before they get really, really sick. So it starts from that, reviewing whether they did a full set of observations, then looking at if the observations were abnormal, what was the next steps they've taken, which usually is set out by the local, I've done few reviews now, Medicolegal as well. So looking at local sepsis management guidelines, the national sepsis standards, and the specialty colleges, what they provide them as well. So especially in the emergency department, there's clear guidance to suggest now with sepsis, it's a national standard. So if you're not meeting that national standard, the hospital itself is in breach. And then going through the steps of saying, were the right investigations ordered? Were they returned in a timely fashion and picked up? And then the other big thing I find is sometimes the episodes between when the vitals were done. So if someone gets a set of vitals and they're abnormal, local policy requires them to repeat the set of observations another couple of hours. And if they're really sick, they have to do it every hour. So if those are not met, you tend to miss deterioration. And then sometimes they go, 6 hours later, he developed sepsis, his blood pressure was 90. Yes, but there seems to be no observations done in the last 6 hours. So you don't really know how long the patient has been septic for. So those are all a lot of issues. And sepsis is not a single state. So you can go into sepsis, they can give you fluids, you get better, and then get back in there as well. So it's that entire journey and looking at all the markers, whether right antibiotics were given, whether they were given at the right time, as the patient has the right amount of fluids, and then have they escalated. So, a lot of times in emergency departments, at least, a lot of these cases get managed by junior clinicians while senior clinicians might be on desk or doing reviewing other cases. But if the junior doesn't escalate, the clinical responsibility for the department when I'm on lies on me, because I'm the senior in charge. So you can't absolve yourself saying, I wasn't consulted, because you are meant to supervise all your juniors in the department.
Yes.
Those are So I
was going to say that, as you've just said, is the classic indication that we see in the medical negligence matters or hospital negligence matters, where the person has actually presented at the hospital more than twice. and been sent home with Panadol or a dose of antibiotics, only to find that it wasn't the right thing.
So in my PhD, I looked at the entire sepsis journey and the data journey, and also whilst I do algorithms now, one part of it was I reviewed about 2,000 patient notes to build a database. And there were times at night I would sit there and cry thinking, what are these people doing? So, because obviously when you look at all the sepsis cases, you're looking at all the bad ones. So it was a great experience, but it was a great insight. Reading through 2,000 patient notes was a good experience.
Certainly informs your amazing expertise. Does anyone have a question that they would like to ask of Dr. Shetty? If you do, you can unmute yourself and speak out. Okay. I have a question from a lawyer who was not able to attend today, and he wants to know in relation to motor vehicle or other catastrophic workplace accidents that involve more than one person, and when the ambulance is bringing several casualties to the facility, how is that managed to ensure that people are, and these are rapid presentations, catastrophic, how is that managed to ensure that the triage process is done effectively and the right person seen first?
So obviously there are disaster processes in every state. We have a clear disaster policy guideline in our Westmead Hospital being a tertiary center. We have a clear policy on that. We do a lot of mock exercises as well. So twice a year we have a disaster planning exercise and training to make sure that we are maintaining the standards, because it rarely happens, but when it happens, it can be bad. Personally, I've had lots of experience of that in India. When I was training back home, we were a big hospital next to a highway, so we would get buses, so truckloads. But that meant 50 patients would end up in the same place. But unlike that, in Australia, we have a very, very good system with the ambulance where they have a disaster triage at scene. And as soon as this is what happened recently with that Hunter Valley incident as well. So as soon as there's a large incident which involves more than 5, there is a code alert that goes out to the state trauma network. A coordinator is allocated to the scene. They do a clinical triage at scene, and based on the severity and acuity of the patient, they get distributed to the local sites based on how much is available. Now, obviously, unfortunately with Hunter, there was there was only Newcastle nearby, but they can then plan and escalate it to get the air ambulance going as well. In the case where 2 or 3 major traumas end up in the same department, if it is a major center like Westmead, we have codes for that as well. So disaster code, then we actually get most of the surgical theaters go quiet and all the surgeons come down, allocate teams. So I've done one of those where in real life, I don't remember what incident it was. We did have the granule incident was before I came to Australia, but we still had a lot of mock exercises around that incident. If that happens to be in a peripheral side, unfortunately, I don't know. I mean, as an ED physician, you would then there's only green, yellow, white, and black. So, white is obviously no injuries. Black is obviously dead or near death. So you usually won't, you would probably leave them, which is very tough to do. And then you do the other 2, which is the red is first, and walking wounded, you will just leave them with first aid and we can manage it that way. So there is a clear disaster triage process there.
Right. I have one last question for you, and I want to preface this with thank you so much for your time and for how generously you've given of this information, and that is in relation to ramping at hospitals. What is the role of an accident emergency physician in mitigating or being aware of or dealing with ramping issues? And I know that those are controlled by the paramedics, but at the same time, they're essentially hospital adjacent.
Yeah, no, look, I've done quite a bit of research and published in that space as well. ED ramping, short stays, models of units. And I'm also on the New South Wales ED task force with the minister. The issue there is, I mean, the hospital is generally responsible for every patient that turns up, irrespective of whether they're waiting in the waiting room or whether they're in the ED room. Now, as a ED physician, when I was there, I would always have a pulse on the waiting room, even though the nurse just triages and they might have triage someone. I usually used to go through the list myself. Even there's 20 patients, you quickly click and just look at what they're happening, because you can get a feel on some patients. In the times of ramping is where the hospital processes become more important, as in providing nursing cover to the waiting rooms. So someone's actually keeping an eye on the waiting room, doing their observations regularly. That is things that the hospital should be responsible for. In regards to the role of the emergency physician, I think as a senior, if you have an in-charge clinician, depends on the size of the hospital as well. If you have an in-charge clinician, they are clinically responsible for patient in the waiting room as well. So there would be an expectation that they at least looking through the notes and saying, okay, which patient, is there any sick ones, or making sure that. So we usually would send our junior doctors out there to just start bloods and start seeing them. But it's a hard one. I think the moral and clinical responsibility in that case would lie a lot more with the hospital than because eventually ramping is because their patients in the back end are not going up to the wards. So
yes, yeah, absolutely. All right. Thank you so much for your time today. That was really interesting and informative. We are absolutely honoured to have you on our expert panel. And to those of you who've watched today, thank you for your time. The recording of this will come out to you within about a day. And of course, it will go up onto our YouTube channel where you can watch at any time. The lovely Dr. Shetty is available upon request to do assessments for your matters. And we look forward to seeing you again in our next specialist sessions. And thank you so much for your time today.
Thanks, Michelle. Thanks, everyone. Bye-bye.
Bye.